Thanks for the opportunity to talk with you today. I feel very honored to speak on this topic and to actually anyone giving up their time to listen. So thank you very much. My name is Deborah Nestel. I work across two universities, the University of Melbourne and Monash. Both are located in Melbourne, Australia. And I've worked with SPs. I'm just going to use the phrase SPs from now on, but referring to simulated participants. I've worked with SPs in Hong Kong. That's where I did my PhD in SP methodology, graduating in 1997. And then I worked in London at Imperial College, and now I've been back in Australia for over a decade. And all of this has actually been over about 35 years. So I witnessed many changes in that time in healthcare simulation generally, and specifically in SP methodology. And I should also declare that my experience covers educational practice, especially simulation design, faculty development, SP development, and I have also researched in this area too. I want to draw attention to an alternative title, and I did propose the first one, so that's my responsibility. I'd shift that first word to aspiring, to aspiring rather than attaining. And it's a tough call to attain excellence every time. I think we need to be kind to ourselves and our SPs and others we work with, that not attaining excellence every time is actually okay as long as we are working towards it. I also want to draw your attention to this word with. And if that is the only thing you take from the session, then I'm going to take that as a win. There's a tendency to objectify SPs in our language, set with phrases such as, we use SPs. It's commonly heard, and I'd really encourage you to think about replacing that phrase, using SPs, to working with SPs. While it's a nuanced difference, it conveys a compelling story of power, distance, and respect, and SP agency. So, important to ask, having read the title, what does excellence look like? And I invite you to take a moment to think about that in your own practice, because excellence is likely to look different depending on whose perspective or lens you're making that judgment from or through. And I think this is so often overlooked. It's important to remember there are multiple stakeholders in SP methodology: patients, SPs, clinicians, learners, SP educators, health and social care service providers, and the broader community. From an SP educator perspective, Lewis and colleagues sought to identify best practices in SP methodology, and this is an important document, and I urge you to look at it, and I applaud the authors, and I declare that I was involved in some stages of their development very early on. However, it is a limited view because it is written by SP educators, largely for SP educators. The article is exclusive of the perspectives of patients, of SPs themselves, of learners, and so on. So it's an important story, but a partial one. The standards are very much positioned in the genre of writing of doing to SPs, again, risking objectification rather than doing with. And why is this important? It's important because without real patient involvement, much SP-based work is a mirror for the teacher's preconceptions rather than as an authentic reflection of a patient encounter. This is sometimes referred to as the clinical gaze. And I'm not suggesting that this is an intentional manipulative ploy of teachers or faculty. I'm simply highlighting the challenge for those immersed in teaching and the delivery of healthcare to see through the eyes of someone who is not, or someone who is the recipient of care. A prominent patient advocate, the late Dr. Rosamund Snow, reinforces this view with her statement that the patient voice continues to be filtered through clinicians' perspectives. She goes on. When no real patients were involved, two major assumptions are made. Firstly, that actors and faculty members who brief them can really simulate patients, that they know how real patients would respond in a given scenario. Secondly, that learning outcomes set by healthcare personnel are the most appropriate for the situation, that real patients would want students to learn those things. The complexity of this challenge of seeing through patients' eyes is evident in the many published accounts of doctors' experiences as patients and how utterly different being on the receiving end of care is to that of the professional provider. And it's not just in medicine. There are examples across the health professions. And for many years, even a couple of decades, professional organizations and licensing bodies increasingly promote active roles for patients and the public. And we see this in broader health services research. Patient involvement in shaping what is research has absolutely gained traction. However, standards of practice for simulation, of which there are many, are largely exclusive of direct patients' voices. While the many standards documents of INACSL offer really thoughtful guidance, but there's almost no mention of patients or even SPs as partners in simulation. So following this thread and getting back to the question of what excellence looks like, I think excellence is when we're getting closer to co-construction of content, especially of patients' perspectives, because I hold very strongly the view that SPs, when the P is for patient, must have real patient involvement at some point, and not every time. That's probably impractical, but sometimes. The idea of co-construction has long been promoted, and I refer to the recent work of Dr. Linda Nikinon and her colleagues, and the title says it all. Nothing about me without me. This is a scoping review exploring patients' contributions to SP methodology. The authors write that simulation-based education must seek to move beyond the paternalistic assumption that clinicians know best. They continue with authentic illness experiences help create meaningful person-centered simulation education. And they conclude, patients' voices profoundly enrich the educational contributions made by SPs. I'm staying with the scoping review a little longer because to me this is what excellence looks like. It is where patients' perspectives are directly informing our practices, and this is an excerpt from their paper, which I'll quickly read. Traditionally, SP's rules have been informed by the clinical gaze. Nastal et al. Urge us to think seriously and artistically of ways to include the person with the experience. An SP can be any person who is willing to take on the responsibility to portray an illness experience, irrespective of having had that illness experience. Central to their role is the need to represent authentic clinical encounters to benefit health professional development and training. It's recognized that such verisimilitude can create anxiety among learners. But the advantage of realism in simulation is to help learners develop confidence, which is transferable to actual life contexts. There are many other influences on excellence in SP methodology, of which theories are also prominent, but often underrepresented. And I'm continuing with underrepresentation. There's no scope in this talk to explore them here, but it's an important area of practice to consider. And I encourage you to seek out the work of Dr. Karen Sauter, who compiles an annual selective bibliography of SP research. I want to move to closing now and again finish with some provocation. Here I argue that making reference to SPs as standardized patients just sends all the wrong messages to how we see and value patients. I prefer to talk about simulated patients who can standardize their portrayal, for example, in an OSCE. SPs are trained to portray their role within a certain bandwidth, preferably informed by real and simulated experiences too. But in plain speak, as an adjective for live humans, the phrase standardized is just unpalatable. Referring to patients as standardized is in tension with their individuality, of notions of patient-centeredness. That's at the heart of safe clinical practice. The phrase standardized reinforces that notion of objectification of patients as cases, stripping them of their personal human qualities. Patients can then become known by their condition rather than their personal identity. It reinforces that notion of the fractured neck of femur in bed 9. So while the phrase is commonly used, I think we need to critically reflect on the messages that we are sending by retaining it. When I shared this phrase with a patient advocate, they reacted strongly with, "You must be kidding, that's so dehumanizing." I offer 5 articles to challenge your SP methodology in your pursuit of excellence. And these are, here we go, that's the letter they're called what. Here are the readings. From Lewis, the Standards of Best Practice guidance. They're really valuable and they're a limited view. Then you can see that I've cited 2 pieces of work of mine, one that's actually quite old now, thinking about authentic patient perspectives, a more recent essay that I wrote with colleagues from around the world where we looked at values and value in SP methodology. There's the article or the book chapter from Rosamund Snow on how real patients can participate in simulations. And there's the scoping review from Linda Nikinon on Nothing About Me Without Me, a scoping review. So in summary, I started by emphasizing the importance of working with SPs rather than using them. I made reference to the many standards documents in Healthcare Simulated and highlighted that while they're valuable, they have a limited perspective. In many, patients are not even mentioned, or when they are, it's not in the context of partners in education. I recommend the scoping review by Nikki Non that shares several approaches to working with patients in SP methodology. And then I invited you to critically reflect on the phrase standardized patient as being in tension with patient-centeredness, preferring the umbrella term of simulated patient when the P is for patient. So thank you. Please contact me if you need access to the references, and I wish you a very happy healthcare simulation week. Thank you very much.